when you go in and share your screen, there's a button on the bottom that says optimize. You have to optimize it. And and there's also
yes, in that, I see it.
And under that says share sound.
So I optimized it, and what else do I have to do?
I think that might be it, unless there's a button that says share sound on it.
I did not see. Let's see. Can you hear this?
That's working. Now it's working.
Now
That's
it's
it.
working.
She fixed it.
Executive
Thank you.
Officer of the Family Medicine Education Consortium. And I'm very excited today to be talking to Bryce Heinbaugh, who is a risk management consultant with IEN Risk Management Consultants. They have 7 locations in Ohio. He is based in Ashtabula, yes, Ohio, up there near Lake Erie, kind of getting all that wonderful snow from time to time. He's one of 210 Health Rosetta advisors, and he's been touched by Dave Chase. Many people know Dave Chase in his recent book, Relocalizing Healthcare, which is actually how I ended up, long story short, connecting to Bryce. I read in the book about Allegheny County Schools in the Pittsburgh area and the amazing project that they had there using the Health Rosetta principles to guide the school districts' health insurance plan. And through that, I learned about Bryce and the work he's doing in Ashtabula. And he told me a story the other day that I think you'll want to hear about how direct primary care and how the principles of the Health Rosetta approach are changing things for the better, dramatically changing things for the better in Ashtabula. Bryce, thank you very much for joining with me today.
Thanks, Larry. It's a pleasure to be here. I look forward to this conversation. I hope more than anything that it helps others. Maybe it's a physician that's really considering moving to the value-based model. It's a physician that just wishes that they could figure out how to gain business among self-funded employers. I hope to share with you how we've done it here in Ashtabula County, Ohio. And I feel strongly that you can replicate it just about anywhere if you have the right team. So happy to be here.
So take me back to the beginning. You obviously got your training through the Health Rosetta Project, working with Dave Chase, and tell me how you applied that in Ashtabula.
Okay, certainly. I'll take you back even a little further, just to kind of give everyone on the podcast an idea of my background. So again, I grew up in this neck of the woods, Ashtabula, if you're familiar with it, and it was on NPR in the fall before the election. It's a working class town, and I graduated high school here. I was raised in a single parent household, and at the age of 22, I found out I needed emergency open heart surgery. At that point in time, I was just finishing up my last semester of undergrad, and really didn't understand, the health insurance problems that I would face. And so inside of a year, 363 days later, I went out on my own, began my own firm, doing healthcare consulting for small businesses. And fast forward about 2 years after beginning, a good friend of mine who at the time was a part of Ohio University's School of Medicine, his name was Tom Campanella. Tom came to me and said, Bryce, I'm headed up to Cleveland, Ohio. I'm going to start to oversee the MBA, the healthcare MBA program at Baldwin Wallace University, and I think you should enroll. And I said, well, Tom, I'm not quite sure. I'm climbing a corporate ladder, but I'll listen to you for a minute. And so one conversation, he had me sold, and I entered into the healthcare program at Baldwin Wallace. And among my 2 years of the program, I shook a lot of hands. And one of the hands I shook was a founder of a third-party administrator in Cleveland, Ohio. His name was Jim Farley. And Jim, from that point on, this was 05, 06, took me under his wing and showed me everything there is to learn about self-funding and stop-loss insurance and how to actively manage a healthcare plan for small to middle market employers. And so I got my start right about the time I left the MBA program in self-funding, and come to find out, Jim and I are very close friends. We talk almost every day. And if anyone knows Jim, he's early 70s. He's been around in this business for 40 years, has seen just about everything there is to see. But one of the things in 2017, he and I were talking about this guy, Dave Chase, who had a TED Talk on where healthcare has been really the largest legal wealth transfer in America. And he was coming out with a book, or had just written a book, The CEO's Guide to Restoring the American Dream. And so we were talking, and then, a couple of weeks later, Jim said, "Hey, did you see Dave Chase is going to start an accreditation program for health advisors and consultants?" And I said, "No, Jim, I didn't." He said, "Bryce, that could be something to really look into." And why is because Dave Chase charges health consultants, insurance, I don't like the word broker, that's kind of status quo, but advisors or benefit consultants, he charges us with being some of the most influential people in America to systemically help change the way healthcare is delivered to employees and their families. And the reason why is because most of the time, your middle market CFOs or CEOs or COOs that are reviewing healthcare renewals, maybe they've not gotten the best advice over time, but if someone who had all of the right alignment, the removal of the misaligned incentives, the right advice comes to them and says, you can do it differently, then that CFO is going to make decisions about maybe 300 or 400 or 500 households on how the healthcare is going to be delivered at that organization. And boy, let me tell you, if as passionate as I am about this business, I know that I can help make that change. And so I joined Health Rosetta shortly after the accreditation program opened up. I've been a great, I guess an adopter of the model, Health Rosetta. My entire firm, we practice Health Rosetta 100% of the time. Like we are, no longer do we have the misaligned incentives guiding the advice or maybe the guidance that we're giving, but instead we're looking to help deliver this awesome, better health outcomes at a lot less cost. And so direct primary care is the fulcrum, in my opinion, it's the fulcrum as well as patient advocacy to the model. And so I'll stay quiet for a moment, Larry, and let you ask me a few questions, but Ashtabula County has been my first market that I've successfully begun to turn the tide with. And again, as a working class city and county, it is very meaningful and impactful financially to the employers, their employees and families, and the community. When you're talking a public school district not having to spend as much money, what can you do with extra dollars that otherwise would have been siphoned out of our small community and to big health systems and insurance companies? So I'll stay quiet for a minute.
Okay. So when we spoke the other day, you gave me a little background information about Ashtabula and about the county school district there. That helped me to understand when you say it's a working class area. But give folks a little background about Ashtabula in the school district.
Sure. Well, again, when I say a working class town, Ashtabula County, depending how you look at it, good or bad, we are still considered a part of Appalachia, Ohio, all the way up here to Lake Erie. And it's we used to have what they called the roughest port in the world. Our shipping and all of our waterways here, we had a very large port. It was the largest on the Great Lakes at one point in time. But we had steel, from the steel mills to, manufacturing. And, again, like many parts of rural America, a lot of it had fallen away or fallen out. And we have a city of about 20,000 people. The county has around 100,000 folks. But in the city of Ashtabula, we are unfortunately a poverty-stricken city. And there are, from public housing to just the same problems, demographics, social determinants that you'd see in any larger city around the country, we have right here amongst this small population of 20,000. And so our public schools, just to kind of bring the perspective real, Ashtabula City Schools is actually, all the kids at the school receive, free a breakfast and a lunch upon arriving at school. And the state and our public school is paying for that because some folks go home on Fridays and don't have another meal. We have just a lot of obstacles, and so the healthcare of Ashtabula area city schools had come off some pretty high numbers year after year, and I had continued to kind of trickle this Health Rosetta information to the administration there, and I wanted them to really just listen. Just can I tell you a bit about how Allegheny County schools have done it? And again, just disclosure, I had nothing to do with Allegheny County, but Dave Chase, connected me to the folks down there that really headed up that consortium and the change that happened in Pittsburgh. And I started to follow some of the steps that they made. And one of the key pieces was they brought their unions together, and they had formed a union healthcare committee, and the purpose of it was to get the union to understand that they, with management or the administration, because of the healthcare industry, they're all sitting on the same side of the table, and the healthcare industry is on the opposing side of the table, because ultimately it's affecting from pay raises or lack thereof to the hiring or lack thereof of staff and the ability to offer extracurricular activities, et cetera. It was all going to healthcare, and so we'd spent a good deal of time working this strategy into Ashtabula area city schools and educating the unions there. And ultimately, what it came down to is I had asked the treasurer and the superintendent for an opportunity just to speak on an educational basis, not selling anything. I just wanted to bring the unions together to understand where healthcare has taken us, taken the schools, their own households over the course of a few years. And ultimately, I was fighting a status quo of a healthcare plan that really hadn't been changed in 15 to 18 years. And that means some folks were used to status quo and used to the way things had always been. And so it's really an entire mindset change that I had to go in and begin to have these folks thinking about healthcare in a completely different manner. And time and efforts, it's a big deal, but educating them on Health Rosetta, the fee-for-service business, by the way, the misaligned incentives of the healthcare industry. What is value-based primary care? What does it mean to actively manage a healthcare plan? And if the number one focus was achieving better health outcomes, what could you do with the extra dollars that would be left over that weren't going to the sick care system that was. And again, in 2019, Ashtabula area city schools had their most expensive healthcare year to date, which was a spend of about $10.5 million on 400 employees and their families. And that's anyone does the quick math, that's I think about a $26,000 a year per employee per year benchmark, and it was terrible.
So when you say you brought people together, and I know in the Allegheny County school system, they created a consortium,
Yes.
and I've even had a chance to look at their website. Is that something that you did with the folks, the labor and the management folks in this school district?
So Larry, I wouldn't say that our strategies were as grand as that, bringing a consortium together. We did bring the unions together, and again, certified and classified folks in the same room, and we're working together even with a number of folks in the room. But ultimately, what I had to do, and this is why I believe that Health Rosetta and Dave Chase and those folks would say, Bryce, you overcame about every barrier you could have had, but we pulled them out of the Ohio School Board Consortium, or OSBC, after I don't know how many years they had been a part of that OSBC. And even with the warning, Larry, that if you leave the OSBC, we will not welcome you back. And that's a big, that was a big wall. I mean, the treasurer said, Bryce, in the unions, are you sure, are you 100% we're doing the right thing? Are we, there's no going back. We've been with this consortium. I want to say at the time, Larry, there may have been about 50 schools across the state that were members, maybe even more. But ultimately, I had to, with confidence, say, yes, we need to do this. Our data analytics, by the way, the very first step we did was put in begun a disease management program, started to get the real-time claims data and predictive modeling, and we got to see the disease state inside the school district. How many diabetics, how many cancers, what were we looking at in the next 12 months ahead of us? And when we started to see the data and the disease states, that is when, and here's the ticket, the very first cost containment strategy we employed, before I even took the district out of the consortium, they agreed to implementing direct primary care on a capitated value-based model. And that step in the right direction was what I would say, was the prelude to unbundling, moving them out of the consortium in the middle of COVID, during a time when there was much uncertainty across the country and no employers wanted to make any changes. August 1st, 2020, we moved all 400 employees and their families onto the Health Rosetta model full on.
Why don't you mention the name of the physician that
Sure.
you worked with?
Yep. So I'll allow me to kind of drill down on this. So again, every private practice physician in this town took, unfortunately, had to either sell out or go work for one of the major hospital systems in Northeast Ohio. And I don't need to name the names, but ultimately, if you know anything about Ohio, our area. But this physician he was the last standing primary care physician in this town before selling out. He had a private practice for about 18 years, sold out, signed a 3-year contract, and quite honestly, his patient panel, before he decided to, let's just say, retire, before he left on retirement, his patient panel, they moved him to 3,100 patients. And he was sick and tired of being sick and tired. A well-established, been in practice, I think his entire career is almost 40 years span. He decided to hang it up. And I happened to catch him. He and I didn't know each other, but we have a nice gastronomy district, some great restaurants here in the historic district. And he and I passed on a Friday night in a restaurant here in town. And I said, Doc, and his name, Dr. Jim Lambros. I said, Doc, you don't know me, but I have a conversation that I'd love to have with you about an opportunity that could forever really change the way you're looking at either retirement or whatever you're doing. And he and I sat down probably within 2 weeks. And we sat down and I laid out this value-based primary care model on a revenue side called direct primary care, where he wouldn't be taking any insurance, no Medicare, not having to deal with any of that gobbledygook. And I said, Doc, my most immediate need is I need this DPC to be launched immediately for my public school district here in town, in which he is an alumni of, which is his Hall of Fame pictures at the lobby wall. I said, Doc, we could change the way healthcare is not only received, but delivered, and health outcomes can improve with this one little strategy of direct primary care, having you go on site to the schools. And in this case, because of the number of employees, I'd like you there twice a week. And by the way, Doc, I've got a couple other clients, a chemical company, a manufacturer, et cetera, that under this value-based model, Doc, I believe that I can hit your capacity of 500 to 600 patients, and I could probably do it within 12 months, all on a capitated rate. And you do medicine the way you were trained and the way you like to do it, 30, 60-minute visits, and let's see if we can turn the health of the population around. He said, Bryce, this all sounds great, but man, I don't even know where to get started. I said, don't worry about it. My connections with Health Rosetta, they're going to connect me. I went out to San Francisco on my own, met the practice software that he uses today. I kind of vetted the people out there called Hint, and they handle all the billing to the employer and the electronic medical record, the EMR system that talks to Hint, and then the telemedicine app Spruce. We came back. I said, Doc, I laid it out. I met with a couple physicians out at the Hint conference. This guy, Dr. Eric Kroll in Tampa, Florida, he laid it all out for me. He's willing to help us, no charge. He will talk to you. Let's Zoom him in. And within 90 days, Larry, we were up and running on a full go with all the software, all the technology that we needed to efficiently launch our direct primary care program amongst my clients here in Ashtabula County.
So just very quickly, I'm going to put you on the spot a little bit. So
Sure.
when did this happen? When did you launch the DPC practice?
Yep, we launched the DPC practice December 1st of 2019. So it's just a bit over, a year and a half
Right.
now. Yep.
Right.
And that was in the schools, December 1st, 2019. And then obviously COVID hit, but thankfully we did it. The timing was beautiful because of his ability to handle patients that were all very fearful. They
Right.
had him on telemedicine. They could text him and, hey doc, I'm not feeling well. What do I do, etc. Perfect timing.
And I know that you're not comfortable claiming success, dramatic success, but you have some very interesting positive numbers that you can share. So what's been the positive impact to date?
Yep. So to date, now again, it is hard, and the reason that originally when we spoke, Larry, when you were doing your fact finding with me, it's hard to measure how much COVID played a role in this in terms of slowing down claims. But we also know the amount of patients that have been seen, the ability to, really, Doc's been able to improve some health outcomes of folks. We've even gotten some of our health. We've got functional medicine health coaches, but we've been able to employ our team and our nurses. And I will say to you, we're seeing, for like the school district, numbers, 15-20% below budget where they had been to where they are today. Our other local manufacturing company and the chemical company are seeing the same approximate numbers as well. The direct primary care physician, Dr. Lambros, has really just become like the go-to. And what I will say to you, we know it's working and we know the word is spreading like wildfire because the uptick, typically every time I've done a DPC implementation from scratch, that first 90 days, we get about 30% of the eligible population to agree to and sign up for the doctor, 30% of that population. And we did, we saw that with every one of those employers, but within about 180 days, we started to see it go 40 to 50%. And within 12 months, we actually cleared over 500 members. I, again, call them members or patients to his practice. Just through, I believe, today, Dr. Lambros has 3 of our local self-funded employers on direct primary care, including the school district. And so that downstream hospital revenue, that fee-for-service misaligned revenue model, we're taking a bite out of it, and the patients are getting better care, more time with their physician.
Now, my understanding, Bryce, is that his panel is now full, and you're seeking to recruit another physician.
That's correct. As a matter of fact, we just met with I am delighted to say, a brand new value-based DPC doc in Beechwood, Ohio, outside of Cleveland, and she is, again, she's from out west, but did her medical school in Florida, came back to, I think, did the residency at Cleveland Clinic, and then right out of the gate decided I'm not going to go part of that fee-for-service model. I'm going to start a DPC practice, and we just met her, vetting her, and needless to say, we're gonna bring her in to a couple of our clients. And then in Erie, Pennsylvania, which I believe, Larry, you know of the Isbicki brothers, Dr. Harry and John Isbicki. We have just brought them on. We spent about the last 4 or 5 months vetting them, making sure we had all the alignment that we needed. We're bringing their practice on board with our first self-funded employer in the Erie, Pennsylvania, and then hopefully can feed them even more in the very near future. So we're seeing this growing, and I can tell you, not only is it growing, but again, you know, that when I say we're achieving better health outcomes, we're impacting these people's lives in a way that the thank you cards and the emails thanking them for either the DPC doctor or our concierge nurses that are working closely with the doc and our community pharmacists right here in Ashtabula, the last standing community pharmacist who we've written into every one of our self-funded plans so that she and our DPC and our nurses can all work together to achieve better health outcomes. We've got a great community health plan started, and I mean it's
Right.
It's so exciting, Larry, to tell you. Last Friday, this was between since calls with you, but we have actually had the good news to say that the city of Ashtabula is hiring us now to take them to the promised land as well. Health Rosetta, and if all goes well, direct primary care with one of our new DPC docs, since we're obviously at capacity with Dr. Lambros.
Right. So I think it's pretty cool that Ashtabula, Ohio, may become the first community to fully embrace direct primary care and its potential.
Yes, and to tell you, a lot more is coming, but we've sat down. We've had multiple meetings with the actual county government as well, with one of the largest self-funded plans in our county, all the county employees, and the county commissioners are still considering moving to direct primary care, hiring us as their consultant, moving to direct primary care. And if that happens, Larry, the cards just continue to fall to this great model, and we start really taking back what healthcare has been taken from us.
That is fantastic. So, Bryce, what's your? I'm going to bring things to closure here.
Yep.
What's your what's the biggest learning for you?
Yep. So I'll say this again, because of the demographics of where I'm located here in Ashtabula, Ohio, I'm finding, we just launched a DPC program at an employer group in Lakeland, Florida. Now this is Central Florida between Tampa and Orlando. Again, same similar social determinants, same obstacles, but we've got a great DPC practice that went into an auto dealer down there. We have over 50% of their population enrolled in less than 6 months. This is big time for us. But parts of the country that are rural or access to high quality care has been a learning experience for us because we're unable to find DPC solutions. And I told you the fulcrum of this model, I believe, from everything we've been seeing, is DPC and working with our nurses in the pharmacy and our Center of Excellence program for high-end specialty stuff. Well, the state of West Virginia, as I said to you when we first spoke, Larry, I've got a really great footprint happening in West Virginia. We've had some great things happen. We've got some clients down there. And right now, finding direct primary care for a rural area that needs it most, that really needs it most, it's hard to go into a new market or a rural market not knowing high quality with the right incentives, the right alignment, physicians that can do what we need to do with care and chronic disease management, working with our team and really getting out of that fee-for-service mentality.
So there's one thing I would like to clarify, Bryce. When you're talking about your relationship with Dr. Lambros, he's running his own DPC practice, correct?
That's correct.
And he's in relationship with you, but you don't own his practice.
I have no financial stake or incentives, nothing at all with Dr. Lambros. Now and again, if there was anything at all, I'd go have a coffee with him and maybe he'd buy me a coffee, and the next time I'd buy him a coffee.
Like a good deal. Sounds like a really good deal.
Yeah.
Well, Bryce, I want to compliment you on the work that you're doing. I've been involved with the direct primary care movement for a long time, and there's a lot of DPC practitioners across the country who've been trying to talk to employers, and quite honestly, a lot have struggled. And I think someone with your skills and knowledge of insurance can speak to employers on their behalf. And this relationship you've developed with Dr. Lambros is just a wonderful example of how that might happen.
Yes, I thank you for the opportunity to make a closing statement here, because let's leave the audience with this. I believe, and one of the things that I have learned is physicians have struggled. They maybe just not sure how to articulate the language to a CFO, and you know, they're maybe perhaps trying too hard. But what I'd like to say is they really should look at the Health Rosetta cohort of advisors, find one nearest them, and reach out and try to work some sort of a you know, an opportunity. I'll talk to physicians around the country, and I'll just say, hey, do you serve on any local boards? Are you at perhaps a country club where you've got some entrepreneurs or C-suite folks that you could just open the door? You don't need to try to sell anything. If I have a conversation with them for you on your behalf, you're a solution set for me every time. And so I would say to some of the physicians that may be listening is look for well-aligned Health Rosetta advisors and let them do the talking, because I believe as if you look at the Rosetta model and the 7 or 8 tenets to the model, DPC is right in the middle, and it does all of what we need to do for risk mitigation and the chronic disease management for our employers.
So one of the things that happened in the Allegheny County School District story is they saved enough money that they were able to invest in their teachers, increasing their teachers' compensation, which obviously is something that's really important for the future of not only our children, but the future of America. You think that's in the offing in Ashtabula?
Yes, I believe so. Now, I will say humbly, we like to call it the Health Rosetta dividend, because if they adopt this and do the change that we advise, when there's those extra dollars, and it may be a few $1 million, it may be a few 100,000, but we like to suggest and recommend, maybe it's pay, but maybe we like to use those words, social determinants of health, but we like to educate those C-suite folks or the leaders of a public school district on proper nutrition, pay, education, safe neighborhoods, clean drinking water, et cetera, so that somehow, some way they can give back those dollars that we've kept on hand in a way that will further the health outcomes of their population that otherwise they could not have.
That's great. That's great. Well, Bryce, thank you very much for talking with me today. And when we put this, in fact, why don't you just go ahead? Do you want to mention your email address if people want to contact you?
Sure, I can do that. Yep. So by the way, our website is www.ienrisk.com, ienrisk.com, and my email address is Bryce, BRYCE, at ienrisk.com. And again, if you email me, I do promise that it will remain on my inbox until I can respond, but I do respond to almost every email I can, and certainly happy to have any conversations with any physician that's interested in, you know, building out a market, especially if they do have some influence to either employer groups, organizations, both public and private, to just start a conversation with. I can help them at least, you know, I believe help influence those conversations.
Bryce, thank you very much. Thank you for what you're doing for your hometown. Thank you for what you're doing for America.
Thank you very much, Larry. It's been a pleasure. And again, I'm obviously, you can tell I'm passionate about doing this. I got a lot of years ahead of me, and we're gonna continue to pound the pavement.
Okay, folks, what do you think?
Well, that was wonderful, Larry. I thought you did a great job interviewing him. He's a perfect spokesman I love the fact that it's something that's working. He approached it as a economic situation, much much like Jed does. This isn't theoretical. This isn't the way it should be. This is just something that actually works. It actually solves the problem for the self-funded employers, the county, the civic organizations. It solves the problems for independent primary care doctors who want to practice the right kind of medicine. Solves the problems for the independent pharmacy. It just creates a whole parallel system. So I just think anything we can do to encourage this and get more doctors to hear his story, and more importantly, more brokers. My big question is, as Dave Chase says, the key personnel seems to be the current crop of healthcare brokers that just are making a bunch of money just by saying, well, I did a really good deal. Your insurance premiums are only going up 12% this year instead of 26% like last year. Let's just keep doing the same thing next year. This guy was new. It'd be interesting to see, why he didn't go down that route and he went this route instead. And I'd be curious to know how this appeals to the brokers. In other words, how does Bryce get paid? Is he making a living similar to what he would have been making if he just did the old route as a traditional broker? The traditional brokers, how do we educate them to sort of make this change? It's a lot of work. They're already doing something that's working for them. They're making money, just like everybody else is making a lot of money in healthcare. Why should they want to change what they're doing? It's kind of like family medicine is mainly fueled by people with sort of a passion and sort of a streak to do something different than the status quo. And I'm wondering how we can help Bryce find more of the third-party administrators and brokers and sort of open their eyes. But how did you find Bryce, and is this a movement that is growing among brokers?
So yes, it is. There was, when Bryce finished, 210 that have been trained across the country. And I have to say, Pat, why would somebody go into family medicine? They could make so much more money. They could have so much more prestige. And yet they choose family medicine. Well, I think this is, I call it a people issue. When I had two conversations, this one and an earlier one with Bryce, and this is a guy who cares about his community. And he's found a model and an approach that allows him really, and this is my term, not his. I think he's much too humble to accept this. He's a hero in his own community. I think that's powerful stuff. And I think there are people out there. Now, do we have a challenge of growing it? I mean, hell, we have a challenge of growing direct primary care among family medicine, period. The woman he's talking to, I did some background checking. She's an internist who came out of the Cleveland Clinic. The Isbicki brothers are two family physicians who have been to our summit. But we have an issue on the physician side to get people to go down this path. And he's got an issue, on his side. But I really think that there are people out there who care about the future of this country. They care about their communities. I mean, he's a guy, and Dr. Lambros, Jim Lambros, who I'll be talking with later this week. They grew up there. And, this is their community, and they're seeing their community being raped. Before you got on, Pat, we were talking about the power of marketing. What if we started marketing the rape of America? And I know that's a negative approach, but, what if there were the stories start coming out that show just how egregious what's going on right now? And we all know it. We're insiders and we know about it. And so we've got we've got a challenge in terms of educating and building. And I'm hoping that this simple interview, which was just a first step, it's very rough, in my opinion. The other thing I want to do is I want to find a documentarian. I want a Ken Burns who will go into Allegheny County, who will go into Ashtabula, and they'll go into other places and really tell the story the way a Ken Burns could tell the story. I mean, that to me is how you change America. But what I am so excited about is we in family medicine have been believers for a long time, and I mean a long time, in what Barbara Starfield told us a long time ago. And we've got to create coalitions with employers and patients. Now, the one thing he didn't talk about here, and I didn't get into, but in the Allegheny County interview that I did, they figured out a way to get the employees to buy into the new plan design. And that was to focus on quality and no co-pays if you pick high quality. And it really seems to have worked. Now, they're a big system. They've got a bunch, they have something like 20 or 30 school districts a part of that consortium, and they're saving tens of millions of dollars across that. So just to respond to your question, I think we have to figure out how do you market this and how do you create the public support for this.
Along those lines of marketing, whatever happened to the big heist that we all raised money for a couple of years ago, the movie?
I don't know.
You don't know what happened to it?
No, I don't.
That's what I was going to ask Dave tonight if he showed up, was where's the
That's
movie?
a good question. That's a good question. I helped too.
Oh, I know. Well, yeah. I mean, I raised money because you asked me to. So
I don't know, but when I talked to Dave, he's on vacation this week. We got our signals crossed. And, you know, the more I thought about it, the more I thought this example in Ashtabula, Ashtabula is anywhere America. Hey, Joe.
Hi.
It's anywhere America. Trust me. It's really blue collar, working class Appalachian. And if it can be done there, it can be done anywhere.
Larry, as you and I talked about yesterday, the great message here is that even without applying the evidence we have around nuancing value-based benefits and nuancing insurance benefits and payment models to doctors so that high quality, high value care is rewarded and low value, low quality care is punished, that even without that, having great access to primary care and a payment model that promotes high value by having a membership fee paid, even, you know, whether it's completely by the employer or mostly by the employer, just having access to that will make a big difference, as we see in this example. Imagine when you start to add to that the power of the levers of value-based design, so that you change people's behavior, you get the employees and the unions on board, you tilt the system to be aligned with much more than just great primary care access. That's step one. But then a network of secondary access to specialists that's all about the same thing. Employers that integrated into a near-site, on-site model of care for their employees as the employers get larger and larger. You know, so many other pieces that continue to add to the savings. I'm very excited about connecting you. I hope you got the information today, connecting you with Mark at the VBID Center. I mean, it's powerful, very powerful.
You know, it was interesting listening to this once again. They connected up a family physician, that's Jim Lambros, with some functional medicine coaches, with a community pharmacist. That's their team. And it's pretty powerful. Wayne, when we were talking
Well, and
earlier,
then he used that to sell it to basically a payer, an employer,
yes,
as a unit. So he got them to work together and agree to a contract that engaged all of that team, even though they were separate entities,
right.
together to work together to provide care to their employees. So he's basically a different kind of saying. And is this the Rosetta model?
It's a piece of the
Is
Rosetta
he
model.
paid by Rosetta?
It's a piece of the Rosetta model. The rest of it has to do with the benefit plan design and the elimination of the hidden incentives. When Bryce was talking about the alignment of incentives, that's what he was referring to. There is so much between the pharmaceutical benefit programs and all of that other stuff. It's just gaming.
Yeah, I mean, Pat's question about who pays Bryce. Who pays Bryce? How does he make a living?
So the companies that employ him, he would get a percentage of that. Now, that's part of the Health Rosetta model. Is the brokers should be paid for an honest service. They shouldn't be they shouldn't be gaming the system to make money on all the hidden the hidden dollars coming in. They should be paid for a service that they deliver. And I didn't ask Bryce how much money he makes or what percentage of a contract. I'm sure there's something like that.
Oh.
Perhaps in the future I'll be able to learn that. But
how does Health Rosetta get these 200 brokers? Do they pay them some percentage, or do they what is their approach? I mean, how do they get brokers to come in and do all the things that they need to do in order?
Yeah, so they have a school, and you get accreditation, and you pay a fee to get that training.
I see. And if you get that accreditation, then you can say you are a broker that can provide higher value care, basically.
Yes.
Yeah. Okay.
So I think Dave has created, call it a brand.
Yeah.
That over time will help these people. The interesting thing is this Bryce is relatively young.
Yeah. He's
a hell of a lot younger than me. And, so his future now, he's got a way of branding and marketing himself. And I can't speak to how much money he makes and how much money he would have made if he was a little more kind of the other way. But I had the sense he's not hurting because he's looking to build.
Yeah, just wondering what his model is, because if you're creating a new type of broker that can go to businesses or payers and say, I have the skills and the training to provide higher quality care, better outcomes, lower costs. How does that work for them? The payers pay him to do that, and then reward some way if he's actually able to do it. And that's locally. I mean, a lot of what he said was local. I mean, and I know this is Dave Chase things. All healthcare is local, right?
Yep.
So it's just fascinating that he was able to broker for a direct primary care practice that wasn't even a direct primary care practice yet, right? He had to talk the physician into doing it.
Right.
A functional medicine nutritionist, I think is what he said, or health coach. And, that brings in what many primary care providers don't know how to do, which is what Joe does, right? And then put that together with pharmacy management service, which everybody needs now because we're flooded with drugs, and then sell that as a team to a payer. That's remarkable. And you can only do it in about 400 or 500 family or patient units because, no direct primary care with an individual physician is going to handle more than that and do it well.
Yeah.
Right.
So, Dr. Jonas, I apologize. I was multitasking as is the cardinal sin, but one of the things that you touched upon, and one of the things that was discussed in the interview that's kind of key is the fact that, so traditionally, and I think, Larry, you said this, the traditional model for health insurance brokers is that they receive a certain percentage of the premiums of a given health player or health plan value. And so their incentive is always to sell the most overpriced plan possible, right? And so
Yeah.
they're not paid, again, similar to doctors in the traditional service, they are not paid by the purchaser, the employers, they are paid by the insurance companies
Yeah.
that issue out the plan that pay them a commission. And
Yeah.
so, the Health Rosetta evangelists, what they're doing by going directly to employers and
Yeah.
saying, if you pay me directly on the basis of value of savings, I'll make sure that you have the right network, that you don't see these year over year increases in premium values because my check, my bottom line will be tied to however much you're saving versus, I get paid by Blue Cross Blue Shield, so why the heck wouldn't I want them to get paid as much as humanly possible by the third party parties?
No, Joe, I think that's absolutely correct. And that is a element of the driver, as long as it isn't just, I get paid by how much you're saving, because it has to be a triple aim bottom line, right? It has to be, you're saving money, but you're also helping, you're improving the patient experience and the provider experience.
Yeah.
The quadruple aim, if you will. So, in the short run, the employer might say, oh, great, I'm saving money. But if their patients aren't satisfied, or if they're not actually improving their health, then ultimately that's not going to work out in the long run. So, but to tie the broker fees to quadruple aim components, and have some simple metrics that could demonstrate that to employers, I think would be tremendous. That would be a tremendous component. I would create a new cadre of brokers like Bryce is, right?
Well, I think you're absolutely right, Wayne. Bryce is not a broker anymore. A broker is just, selling something for an insurance company. Bryce is creating a whole new business. He's getting people together, he's getting people to work together, and he's got to keep working on it. This whole thing could fall apart if Bryce goes away as sort of the glue that holds it all together. So he's done a lot more work than any broker ever does.
Yeah, but isn't he a broker for the payer though? He's a broker for the
employer,
company. Employer, right? Yeah. The employer. That's who he's the broker for, not the insurance company. He's still a broker.
Right.
He's still
what I'm saying is
still putting it together and helping them figure it out, right?
One of the reasons all the brokers aren't shifting to this model is it's a whole lot more work. It's a whole lot more. I mean, he had to create this whole healthcare network and system.
Exactly. No, I understand. And the money, there's not a huge amount of money compared to working for the insurance company, right?
Yeah.
Well, there might be. There might be if he gets a big chunk of the $1 million that the
so here's my question. So here's my question for you all right? You guys are smart people and do this. Is there a policy shift, a policy recommendation that could drive brokers to do what he's doing?
Yeah, there's a
question.
There's a very simple one. Most insurance outside of ERISA plans is regulated at the local level, at the state-based level, right? So most states have a cap on the percentage of commissions that are available to insurance brokers. And so if you could leverage like the National Society of Insurance Commissioners, state insurance commissioners, and say, hey, brokers shouldn't be able to earn 2 to 3%. They should be able to earn 1 to 2% on commission sales. You could pretty quickly
unless
change.
They did this.
Unless they did this. Oh, I mean,
unless they did this, then they could earn more, right?
Yeah, or maybe just say that these value plans fall outside, right? Because they're not earning a commission of premiums; they are being paid on a value basis.
That's
So
great.
it'd
That's
be,
a great
it might
idea.
create an opportunity for others. And I mean, I really look forward to having Dave on. Like the Health Rosetta, that group is pumping out like a whole generation of these
Yeah.
brokers, right? So like David Contorno is another great example of this out of the Southeast. And you know, David Contorno, and I'm trying to remember the name of the academic that he's working with. Larry might know. David, or Larry, do you know David?
I know his name, but I don't know him.
So he's working with an academic, and I'm trying to remember his name, but they actually set up a graduate certificate degree for training insurance economics on this basis of this, like the Health Rosetta basis. So like, you know, they have an academic curriculum for this functional purpose. And so like there's a generational shift, and not like age wise, but in terms of like of brokers who are looking at the employers getting really fed up of year over year premium growths and are looking to jump on the bandwagon before the employers pull the trigger and say, screw it, we're doing it ourselves.
Right, right. So Joe, let me ask you a question here. You're a great policy wonk. You know this area and all this field very well. Could you write a recommendation for a policy shift that could do exactly what you just described to me, which is to something that could drive brokers from the insurance broking industry to this type of value-based? Is there a way to language something? And again, for policymakers, it's got to be very simple, right?
So I would
that
not.
Could be inserted into a recommendation for national policy or state policy.
I mean, I would be very surprised if Jay Keese with the DPC coalition has not been thinking about this. I know, you know, Phil Eskew's probably, or Dr. Phil Eskew's probably thought about this, right? Like there's a number of these kind of policy and legislative engagements around the country that I just honestly don't think about at all anymore since I left the AFP and don't wear an advocacy hat anymore. But like they're there.
Well,
We just need to find out how to tap into them. And you know, Larry knows Jay well.
Well, I mean, and I'll tell you why I asked that question. Okay, so the advanced or the high quality primary care study is going to come out in a month. Okay, and they're going to have a financing section, and they're going to talk about increasing the cost or the money going into primary care, et cetera. But the question is going to be, and I hope they will address this, I think they will, is what type of primary care, okay? And it has to be primary care that hits the metrics, that hits value-based metrics. Okay, that's wonderful. So we've just launched an NAM study on healthcare finance that will come out in the fall. And I'm hoping it'll come out with some recommendations. I don't know. I can't control it. We already launched it. NAM's doing it. We can't influence it anymore. Well, we can influence a little bit, but not much. But if there was a simple recommendation for brokers to say, here is a way in which a recommendation could shift the contracting process between healthcare and payers to increase value-based components and incentivize people to do that, like Health Rosetta is doing, okay, then, you know, I feed that to them. I don't know if they'll do it, but I'll feed it to them and say, all right, and there's an administration that might be willing to listen to that. So just putting that out there. That's why I'm asking that question.
Yeah, no, that's a heck of an opportunity. I mean, Larry, it very well might be worth when Dave gets on. I mean, it behooves Dave Chase and Health Rosetta to keep track of any policy opportunities to expand the incentive system for health insurance brokers, right? Because For every insurance broker that moves into this kind of
Yeah.
value-based world, they pay Health Rosetta for the certification and all that. So, I mean, he probably is very aware of like what areas and opportunities there are, but like insurance regulation is just it is arcane stuff.
Yeah, it sure is. It is
So,
bizarre. It's hidden.
yep.
It's imposed by lending. I mean, it's a really a bizarre system. Well, I'd love to do that. You know, I spent an hour talking with Dave about this, and I learned more, Larry, to your credit, from this local example than I did from spending an hour talking with him. I think I understand what he's trying to do better from this example than I did from his explanation of it. So, anyway, thank you for doing that. So,
Len, I think you had a question or a comment.
I was just going to say, we're all zeroing in on what I think we need to conclude, which is the most important tool that would make a lot of what we've been talking about happen, would enable and empower it, is some kind of standardized national way to have a composite quadruple aim score that
yes,
you could apply.
exactly.
If we had that, and then
Yes.
you could say brokers should get paid based on how they improve that composite score,
Yes.
right? And other ways that we could use that score. But I've been trying for years to get employers to pay attention to that. They're so stuck in the broken system, it's hard for them to see
Yeah.
that. But that would go a long way to help policy change be based
Yeah.
on something. You know,
Yeah.
some kind of a validated composite score of you really are improving value, you really are risk adjusting the right way against the patient population, so it's fair, and so forth and so on. That would be a magnificent step forward.
Yeah.
I agree with you completely.
So given that extremely astute observation from Dr. Farmer, Len, when are you going to have Professor Etz on the line to talk with us?
Larry?
You ask Larry or Len?
Oh, sorry, Larry.
Larry.
Yeah, I meant to say
Larry,
Larry.
yeah.
Yeah,
So literally, Rebecca and I are talking tomorrow.
good.
We talk once a month.
And she was on the primary care committee, you know, that's
Yes,
coming
she
out. She
was.
was on that.
Yes,
So I assume there'll be some of those
she and
metrics
Bob
in there.
Phillips, and
Yeah, but I think
hope
Len's
so. If they're not,
exactly
there's
right.
something wrong.
There has to be an adopted standard that hits that looks at the composite triple aim instead. When you do this in those, you know, 3 areas at least, or if you care about, right, or care about providers, you know, then you get paid more. Yeah.
That would be a fun exercise for this group. We could bring in Rebecca, we could bring in
metrics.
Jay Keys, we can bring in Dave Chase, but to come up with a statement, for lack of a better term, that would point this in the right direction. And I do think, you know, I'm not directly connected with the National Academy of Medicine the way you are, Wayne, and the way Joe is. Joe Sugar, that is. But I think that if we had something, you know, to feed into them, so to speak, it could influence things. At least I hope it could.
Well, you know, the primary care report is done. It's done. Okay, so there's no influence on that, and it's going to come out. But I think it's going to have a lot of these principles articulated. So I think there'll be a lot there that we can use to market and communicate. So I think when that comes out at the end of the month, we should really look at that and maybe have Bob Phillips on or others or something. And Rebecca was on, she can articulate it too. You know, but then the next issue is the money flow, as we were just talking about here. How can we tie the money flow, the metrics, in a way that will drive people like Bryce to go into the field of value-based brokering, whatever you want to call it, you know? So. And that we could feed into, the reason I say that is that could be fed in to the current ongoing study. I could feed that into the current National Academy of Study on financing, financing for health. And whether they'll take it or not, who knows, but at least we could keep feeding it. And they've been talking about that. So I think there's a receptivity there to do that.
Wayne, if you look at, you know, who benefits the most, and Lynn, who benefits the most from a approach that really gets a high composite score on the quadruple aim, financially and productivity wise, it's the employer. And by educating these brokers to educate the employers how to make this really, it's really a dramatic shift in even thinking about healthcare and the financing of healthcare. It's a paradigm shift for sure. But the people that are most highly motivated are the employers, and then the brokers are the ones that have the most influence on them. So I think Dave's done a great job of focusing on educating the brokers. I guess the question is, how did he get 200 people to get accredited? And what about the other 200,000 brokers out there that are ignoring him so far? You know, that's the real inflection point is how do we get more brokers to turn into Bryce instead of doing what they're doing and making a good living, just status quo like everybody else in corporate healthcare.
To use a phrase from my youth growing up in New York, money talks, nobody walks.
There you go.
Yeah.
Yeah. So
Well, Larry, I would suggest one way to help execute on Pat's suggestion here is to send this over to Scott Kennard and Mike Thompson,
Yes.
you know, in the National Alliance of Healthcare Purchasers, who are the private payers,
Yes.
and say, hey, let's do something for.
You know, Mike Thompson has been at our DPC national summits, for the last 2 or 3 years. He is and Scott Kennard, Mike Tuggy, Jed Constance, and I are talking with him on like a once a month basis. So one of the things I will do with this interview, this podcast interview with Bryce, is I'm going to be sharing it with, Scott hoped that he could be here on the call tonight, but I'll be sharing this interview and this recording and this conversation here tomorrow with everyone. But I think we are accumulating or developing connections among shakers and movers. And I think this is what we have to do. Len, I love your idea of figuring out how do we create metrics that would reward the brokers, because the brokers will, I mean, sales is their job. What's interesting is, you know, Bryce and the people in the Allegheny County schools, by the way, they figured out how to build these bridges between labor and management. And Bryce did that in Ashtabula. I'm quite sure that's not part of the skill set that they get taught when they go through their traditional MBA training. So, really impressive to me that that people can figure out, and maybe, you know, we can share this story and people can learn from Bryce's example. And I'll share this with Dave Chase too, because Dave doesn't know about Ashtabula yet.
Really? Yeah, that's interesting. Yeah, I mean, it's about local alignment between leaders that want to improve the health and well-being of a community. And who do you need at the table to make that happen locally? And it's that kind of integration. That's what the brokership is about, right? It's about well-being and health for the community. You know, that's fundamentally what the brokership is. And they have to have the skills and ability to do that. You know?
Yeah.
Interestingly, I thought there were no politicians involved. Zero.
No wonder it worked.
Yeah.
Yeah.
Well, they don't know
No
squat
wonder it worked.
about, they don't know squat about this stuff. I mean, now, you know, Bryce was saying now that they've got a successful model there with the school district. Now the county government and the city government are saying, hey, can we, you know, can we be a part of this? That's
Oh.
when things will get really messy because the insurers and the brokers who are using the traditional model are going to start using their influence on the politicians.
Yeah.
Yep.
So Larry, I have a suggestion for a future meeting, and that's
Yeah.
Kathy Bossi. So Kathy Bossi is the former chief medical officer for Dow Chemical Company. And when she continued to work, you know, in alignment with Dow's interests and had, especially around cultivation of community health, she set up an entire community alliance group, a nonprofit. Eventually, it formed into a nonprofit for an area in Michigan where Dow's headquarters is, but it's now going out over. And she created a entire community alignment around creating health and well-being, and it was supported by Dow, okay, the company. But it was she was acting like a broker, and she created metrics for it and input by community funders and philanthropists and other companies and the healthcare workers and that kind of. She's a primary care. She's a family doc. So,
What's her name?
Kathy Bossi, Basse, Kathy C-A-T with a C, Basse. So it'd be great to have her come on and describe how she created this community health improvement coalition, if you will. Again, I don't know what she calls it. She calls it something else, but it is an incredible model, and they've really built metrics for a local community that are nationally of value. I mean, they're not just local; they're a core aspect of how to. And the way they've done the community development to get all the people on board. She's sort of broker, but she's not hard to be a healthcare contract broker.
Yeah.
You know, like Bryce.
So
and anyway,
could you introduce
she'd be
me
a great
to her?
one to have. Absolutely, I'll connect you. Sure.
Yeah, I would appreciate that. So let me tell you the other thing that's going to be coming out soon. So I've written about a 2-page document that basically said this, that given the breakdown in our primary care and public health systems in the pandemic, I think it's creating an opportunity for primary care and especially family medicine to step forward and say, look, here's what needs to happen so we have an effective primary care / public health system in the United States. And my sense is that AAFP, other family medicine organizations, they are waiting for somebody to ask them what needs to be done. And I think it's time to proactive, especially with the NAM report coming out. And so I'll be talking tomorrow night with the executive committee, my board, about publishing this challenge to the family medicine community. And the reason I'm speaking to family medicine is because it's the last big dog standing to represent primary care. We can invite the general internists, we can invite the pediatricians in, not their specialty organizations, which aren't interested in primary care, are interested in protecting the subspecialists, but we could create a coalition and we could articulate what a primary care driven system, starting at the practice level to the community level, like what you're talking about, to the marketplace level, to the state level, to the national level. And we could put in their policy recommendations. And so I think my executive committee is going to approve putting this out. I think those of us who are in this group and others could come together. I would not look to AAFP to lead this because I think they'd put it into committee and study it for a year before anything would happen. And I think there's a timeliness to this issue. So I want to mention that to you. And you know, I'm just going to put it out there to everybody I'm connected with, and see who chews on the idea. Any reactions to that?
And I think that's great. When you talk to Rebecca Etz, ask her about this leadership group she's pulled together of the top 7 primary care groups to see if something like this would
We have talked,
resonate with that at all. I don't know if they would or not.
it would not actually. She and I have talked about this. And the reason is, you know, that group was pulled together with the idea that Congress needed a single voice to speak for primary care. So they were able to overcome their differences with Rebecca's help, by the way. She was right in the middle of that whole thing. I'm not sure, I mean, I'll ask Rebecca tomorrow about this, but I'm not sure that these specialty, you know, American College of Physicians, you know, and a very limited issue, they can speak for primary care. But I have my doubts that the big organizations or even the nurse practitioners would be willing to go along with what I'm talking about, a primary care driven system. At any rate, that's sort of maybe it's my bias, but
Yeah, well, I mean, it may be that needs to talk about, we need to find out about how to market this, right? I mean, it may need to be reframed as no matter what specialty you're in or who you care for, you have to take a whole person approach and align yourself with the health and well-being of the person as a entire person. And that has to be a core part of how you talk to people, get paid, the services that you provide, and how you get paid. So,
right. Okay. Well,
Yeah.
this has been an interesting
All right.
conversation. It's still being recorded, so I will share this with everyone in the larger group, and I will be sharing the Bryce Heinbaugh podcast with a broad array of people. And Joe, I should ask you before we finish up. I mean, you're the executive director of the Direct Primary Care Alliance. So what's your take on what Bryce had to say, and what do you think the DPC community might think about this?
So, as you all know, the DPC community is a fractious bunch. We tend to very strongly adhere to labels, but I honestly think that you are seeing kind of a growth. I've had more conversations with DPC physicians about the fact that the self-limited model, kind of the cowboy on the prairie model of direct primary care, needs to scale in a way that I hadn't had in the past year ahead of it, right? So enough DPC physicians have reached the point where their practices have grown and their business interests have grown that they are thinking about, okay, so I'm going to drop this nomenclature of being pure, quote unquote, and I want to figure out how to actually best serve my patients while maintaining a living, right? So the advent of the Health Rosetta framework to serve as a bridge for a number of DPC practices, not all DPC practices, is a truly fortuitous development. And you see a lot of practices who come to this linchpin point of, do I want to expand? Do I want to scale? Looking at employer purchasers as the logical framework for doing so. And through that, they start asking questions like, okay, I know that I went into this to do everything from mop the floor to, call patients, but maybe I should hire a nurse. Maybe I should revisit this whole team-based care concept. I don't need 11 FTEs per physician, but maybe I should have someone, maybe it shouldn't be me calling someone about renewing their meds. So it is an interesting kind of juncture.
So you're saying they might be positively
Yeah,
disposed?
I would say so.
Okay.
At least there's a receptivity and an appetite for it, and in a way that culturally, I think, hadn't necessarily always been the case.
Okay. So any final comments?
One last one, Larry.
Len-
Thank you so
Len,
much.
you're muted.
Oh.
Len was starting to talk, but he was muted.
I was just saying, excellent session. Loved it. Very, very important, very productive. 2 big thumbs up. And I've got to run because I got people waiting on dinner because it's still only 6:35 here.
Okay, enjoy your dinner. Pat?
I was just going to say, we might want to circle back. Bryce first heard about this whole Rosetta concept and the whole DPC concept, I believe, by a professor at his educational program where he was getting his master's. So
Yeah.
maybe another leverage point would be the educators. You know, I think Family Medicine Education Consortium thinks educators somehow have some impact on the future of reality. So maybe some programs for the people who are creating the training programs for the brokers and the masters in healthcare administration would be another leverage point.
Okay, thanks for that.
I enjoyed it very much. Thank you. It's good to
Good.
talk to you. It's great.
Take care all.
Always good to see you
Okay.
guys.
Take care, everyone. Thank you so
Bye-bye.
much.
Yeah. Bye-bye.